Welcome, folks. Today we are discussing magnetic resonance imaging, MRI, of the postoperative meniscus, a challenging area in diagnostic imaging.
I'm eager to hear more. What are the main challenges in imaging the postoperative meniscus?
The primary challenge is differentiating between normal post-surgical findings and new meniscal tears, or healing failures. Prior surgery significantly complicates MRI interpretation. The goal is to accurately identify the source of persistent symptoms after meniscal procedures.
So, how does the extent of the initial meniscectomy affect the choice of imaging technique?
That's a key point. For partial meniscectomies of less than 25%, standard MRI is often sufficient. However, for those exceeding 25% or after meniscal repair, magnetic resonance arthrography, MRA, either direct intra-articular or indirect intravenous, is generally recommended. The decision between direct and indirect MRA depends on patient tolerance to injection and the presence of a significant effusion. A large effusion makes direct injection less crucial, favoring indirect MRA.
Interesting. Can you elaborate on the differences between direct and indirect MRA and their respective accuracies?
Certainly. Direct MRA involves injecting contrast material directly into the joint, while indirect MRA uses intravenous injection. Studies show that direct MRA boasts higher accuracy, around 87%, in detecting recurrent tears after 25% meniscectomy, compared to standard MRI, around 65%. Indirect MRA offers similar accuracy to direct MRA, but is less invasive and potentially more comfortable for patients with pre-existing effusions. A study comparing MRI direct and indirect MRA for recurrent tears showed indirect MRA had the highest accuracy, 93.8%, followed closely by direct MRA, 92.9%, while MRI lagged behind 62.5%.
That's a significant difference in accuracy. What about the interpretation of MRI findings after meniscectomy? Are there any pitfalls?
Yes, there's a phenomenon called intrameniscal signal conversion. A well-performed partial meniscectomy can convert pre-existing intrameniscal signal into a grade 3 signal, mimicking a new tear. This is crucial for surgeons to understand when interpreting post-operative MRI scans. They need to consider the amount and location of the previous resection, the overall size of the residual meniscus, and the appearance of the meniscal horns and margins. If less than 25% of the meniscus was removed, standard MRI criteria are more reliable.
And what about imaging after meniscal repair? How does that differ?
Evaluating patients after meniscal repair is even more challenging. Increased signal intensity, even a grade 3 signal, can be expected after successful repair, reflecting scar tissue formation. Distinguishing this from a new tear requires careful consideration of several factors. A grade 3 signal with increased T2 weighted intensity, a tear outside the repair site, or a displaced meniscal fragment. The literature on MRI versus MRA after repair is somewhat controversial, with some studies suggesting MRI is insufficient, while others report high accuracy. MRA, both direct and indirect, can be helpful, but interpreting the enhancement of reparative tissue can be difficult.
What about meniscal transplantation? How is that assessed with imaging?
For meniscal allografts, MRI is often used to assess meniscocapsular healing, allograft extrusion, and tears. However, signal intensity changes during remodeling are common, and the correlation between MRI findings and clinical outcomes isn't always clear. Some studies show good correlation with second-look arthroscopy, while others don't find a strong link to clinical outcome. There's a lack of research comparing MRI and MRA in this context. Weight-bearing MRI might be beneficial in the future, but current technology has limitations.
Are there any alternative imaging modalities if MRI or MRA are contraindicated?
Yes, computed tomography, CT, arthrography shows promise. Studies using CT arthrography with second-look arthroscopy as the gold standard have demonstrated high sensitivity and specificity in detecting residual or recurrent tears after meniscectomy. It's an invasive technique similar to direct MRA, but it offers a valuable alternative when other methods are not feasible.
So, in summary, Choosing the right imaging modality depends on several factors, including the type of procedure, the extent of the initial resection, and the patient's clinical presentation. It's not a one-size-fits-all approach.
Exactly. A thorough understanding of the strengths and limitations of each technique, along with careful correlation of imaging findings with the patient's clinical picture, is crucial for accurate diagnosis. Future advancements in MRI technology may simplify the process and potentially reduce the need for invasive procedures. Thank you for listening.